So I'm here at ASH 2023, and I have the opportunity to present on behalf of my co-investigators Abstract 319. This is the safety and efficacy for patients that received azacitidine 75 mg per meter squared for 7 doses in a 28-day cycle, plus Venetoclax 400 milligrams daily, dailies 1 through 14. And that is the recommended phase 2 dose. So I got the opportunity to present 107 patients and what their outcomes were. This was an older age population, with most patients having greater than 5% blasts, and in fact half had greater than 10% blasts, so truly a high-risk population. The IPSSR was greater than 85%, included patients with high and very high risk. The mutation spectrum was pretty classic for a high-risk group, including mutations in RUNX1, ASXL1, and TP53 and SRSF2. So it's a well-represented group, which is often very challenging to collect in patients for an early phase clinical study. In this trial, we were able to demonstrate the expected cytopenias that we know with azacitidine venetoclax combinations, and we were able to demonstrate that there is a febrile neutropenia rate of 42%. Because there is known cytopenias, the protocol does have modifications for the doses, dose interruptions, and it mandated antibiotic prophylaxis. And that really helped to mitigate severity of infections or of fever illnesses that we can see with these combinations, allowing patients to continue on treatment and to recover. And I think that's really important. The overall 60-day death rate was 6%, showing that it's tolerable, safe, and that's better than what we would have expected with a myelosuppressive regimen, showing that their scheduling was really impressive. And that really translates because the overall response rate from objective responses with CR and marrow CR, regardless of hematologic improvement, is well over 80%. A full complete remission was captured in nearly 30% of patients, and additional benefits were seen with marrow CR plus hematologic improvement as well in about 20 out of 107 patients. So we were very happy to see really deep responses meeting the strict criteria that was enforced by IWG 2006. What's really meaningful, because although CR is important, we were able to see that the time to response is just over 2.5 months. 40% were able to be bridged to transplantation, which remains the only curative modality for patients with high-risk MDS, showing that the regimen was safe and able to bridge patients, which is really important when people are waiting for their donor or they're not quite ready for a transplant based on performance status. The median overall survival is 26 months, which is really impressive. The median duration of CR is 16.5 months. So again, median overall survival 26 months, median durability of CR 16.5 months. And if you remain in CR, the median survival has not yet been reached, showing clear benefits of a very active regimen with a really good transplantation bridging rate, and benefit among those that did not yet are not yet candidates for transplantation or will not be based on age or comorbidity. So we were able to highlight these really fantastic responses, and we are looking forward to seeing what happens with the phase 3 study, which is ongoing, with azacitidine plus placebo versus azacitidine plus venetoclax, because in reality we really need a randomized trial to demonstrate true survival benefit, and we really need a new regimen for high-risk MDS. We've really been relying on primarily frontline hypomethylating agent or DNMT inhibitor therapy such as azacitidine or decitabine, and the real-world experience is that median survival in those cases is really 17 to 18 months. It's been very hard to recapitulate the data from 14 years ago from the original AZA-001, where it showed a median survival of 24 months. There has been recent data from a small cohort through the GFM or French group, which looked impressive, where they did see a 23-month azacitidine survival. But outside of that study, it's been very hard to recapitulate in the real world, showing us that we really need something more than just azacitidine. An additional abstract that my colleague Dr. Garcia presented this weekend includes taking a look at the patients on this phase 1b trial with azacitidine plus venetoclax. This is not a randomized study, and frontline high-risk MDS patients who did go on to transplantation. Just over 40% of patients went to transplant overall, and in this study he presented what happened to these 50-51 patients, and overall the punchline is the outcomes are good. Most patients that went to transplant had an objective response of a complete remission, and so they went in with excellent disease control, and the median survival has not been reached, suggesting that this is a really good bridging regimen for patients if they're able and needing therapy before transplantation. It's really noteworthy that in the CTN trials, they've demonstrated transplant is important in first-line therapy. When you look at the detail of subsequent CTN studies, they emphasize myeloablative conditioning or high-intensity conditioning is really the best modality for long-term survival. However, the reality is most of our patients are older age and can only get a reduced intensity conditioning transplantation. So how we can improve the outcomes of patients that are curable, I think remains very much on the table, and this data preliminary looks very encouraging for them.